से क्या होगा, and we are all hoping कि अच्छा ही रहे आगे, keeping the fingers crossed. And now the media is talking about the third wave, second wave तो handle नहीं पा रहे हैं, third wave की जब बात, president of AIU and
President जी तेज प्रताप बोल रहा हूँ.
He is Vice Chancellor of GB Pant Agricultural University. The President of AIU happens to be the senior most Vice Chancellor of the country. So he is the senior most Vice Chancellor of the country.
But how are you looking so young?
ये आपकी दवाई का असर है. अब थोड़ा आगे के लिए कुछ बताएं, वरना बुढ़ापा छा जाएगा कोविड के डर से.
Okay, sir. We would like to start. Okay, sir. So, Dr. Tej Pratap sir, and we are very happy to find Dr. Naresh Tirang sir. Sir, you are so kind that you really find time for us and some doubts so that can be out from the mind. So I want formally to begin this program, and for your welcome, I would like to invite our Secretary General, Madam Pankaj Mittal ji, to welcome address, and then after our President of AIU will basically give a remarking address in this regard, and then the program will start. The program is designed in such a way, and half hour is basically lecture, and already Madam mentioned that half an hour time for the question hour. I think people have too many questions.
Year 2021, we felt that we have conquered the virus and we started opening up slowly. But then we were blown away by a severe second wave, which swept us off our feet, which at present seems to be unsurmountable. It is very disturbing to see the rise in number of obituaries in the newspapers and the people losing their loved ones in these unprecedented times. We are all in the same boat and facing tough times, but I strongly believe that such needs is strong and efficient to speak to all of you on COVID management and health. Dr. Naresh Tirang ji is a reputed cardiovascular and cardiothoracic surgeon. He graduated from King George Medical College, Lucknow, went to New York University Medical Center, Manhattan, USA, and practiced there for this program, and look forward to a very informative and exciting session ahead. Thank you very much. Thank you.
Thank you, Dr. Mittal.
I would like to, sir, invite you for opening remark, our AIU President, Dr. Tej Pratap, sir.
Thank you very much. Just एक मिनट लूंगा tirang ji. Honorable Padma Bhushan Dr. Naresh Tirang ji, and all of you colleagues from different universities, vice chancellors, deans, and senior colleagues जो आज tirang ji को सुनने के लिए आए हैं. I would just only pass on behalf of all my colleagues your appreciation of this gesture. tirang ji, इस वक्त आप निकाल के हमारे से बात करने के लिए आए हैं. It's really great indeed. Taking cue from Madam Mittal, आजकल हमारी बड़ी अजीब स्थिति है कैंपसेस में. यूनिवर्सिटी कैंपसेस लिविंग इन फियर एंड अनसर्टेनिटी. इंडिविजुअल तो इन्होंने बता दिया. हमारी मुश्किल आप थोड़ा सा जोड़ें यूनिवर्सिटी के हिसाब से भी. हाउ टू अवॉइड इन्फेक्शन, व्हाट नॉट टू डू एंड व्हाट टू डू. आजकल ये भी बड़ा मुश्किल है कि हम कई चीजें ऐसी करें जो नहीं करनी चाहिए. बट देन व्हाट नॉट टू डू एंड व्हाट टू डू to avoid infection. अगर लग ही गया, then how best to manage the infection, corona. Then it is also individual, family, और हमारी जो responsibility है कि अभी तक हम अपनी बात कर रहे हैं. Campuses में infection को avoid करने के लिए या लग गया तो manage करने के लिए हमें क्या कुछ अगर थोड़ा कोई advice दे पाएं तो would be very great. Then the third is how best to advise campus staff and students. मोटी चीजें कि भाई what to do and what not to do. और लास्ट में जो आजकल की सबसे बड़ी परेशानी है मेडिकेशन मैडनेस. मेडिकल मैडनेस से आप समझे होंगे इतने सलाहकार हैं, काढ़ा, गर्म पानी, ये दवाई वो दवाई के जो करना है वो तो नहीं कर पाते हम, जो नहीं करना वो कर लेते हैं. तो ये हम आपसे सुनना चाहेंगे कि असल में क्या अवॉइड करना चाहिए. व्हाट इज द professional advice to us. With these words, I once again welcome you here and thank you very much. Really appreciate your gesture for sparing the time. Thanks indeed. Over to Tirang ji.
All India level ऊपर के चल रही है.
I would like to request everyone kindly mute the mic. Kindly mute the mic.
All India account, All India University.
Lokesh Janji, please mute your mic. Lokesh Janji, please mute your mic.
उसमें जुड़ने का
Yeah, from the host side, can we mute everybody once for all? Lokesh Janji, please mute your mic. You're disturbing everybody. Thank you.
So
Hello.
good evening, and I'm, like I said, I'm privileged, and it's my pleasure to be in such distinguished company. And all of you have actually contributed more than me for sure. So if we were to look, I would rather put it as then and now. So as mentioned already, that the first wave of the COVID-19 that came to India actually was part of the global system, but took us as much as surprise, as much as shock, that something like this could happen in modern times. So when it actually started raging in the first wave in India, in all wisdom, there was a lockdown declared, knowing very well that if we did not do that, that the virus would spread wild and high. The other part of it was that in the medical infrastructure and in our psyche, we were totally unprepared for an onslaught like this. So that lockdown of 3 months, as was done quite appropriately, did two things. One, it broke the chain of spread. It slowed down the numbers, and it gave us an opportunity to actually develop the infrastructure and the attendant equipment and other things like PPEs, masks, ventilators, medications that were not in adequate supply in our country to even support the first wave. So when the unlock happened and we gradually returned to activities, there was a general sense of relief because people had been locked up for 3-4 months. And especially when you look at our culture, when we are very social people, we are very emotionally attached, and we are very physical in our relationship, that people started slowly, gradually increasing, some in uncontrollable desire and some in disbelief or ignorance. So we started seeing bigger and bigger parties. People started thinking that the virus has actually disappeared and they could actually indulge in their usual habit of socialization. Then came Durga Puja, then Diwali, weddings started happening. They started with 10-member wedding to then 500-member wedding. So all these events, then including Christmas, Holi, the Kumbh, and then finally the elections. So all these things were a recipe for disaster to begin with. But when the second wave hit, we did not ever imagine that it would be so fierce. The velocity and ferocity would be of this level that it would surpass the previous wave by 4 times, 5 times. This is the data we know. We don't know how many more people are actually getting infected a day. And if you look at it from the scientific community believes that maybe it's 3 to 4 times that of what we know because of that you're not testing everybody. So of course it has knocked us back on our behind, where we thought that we had fought the first battle so well that our data of recovery and deaths were almost better than anybody in the world. So naturally, the medical profession, the paramedical people, the frontline workers, we had worked hard for all these months, but also we were very proud that we came out looking responsible and, as compared to the world, better than anybody else. So we also knew as hospital providers that a large number of people had been left out, who were non-COVID, who needed treatment but could not reach us or were scared to stay at home. So there was this other part of the world which was also in real trouble. And we started, actually by the end of last year, we started getting more and more people into the mainstream and started treating them because their treatment has been denied for over 6 months. Now what's happened is that we find ourselves that the infrastructure that we had for the first time is not adequate, and this multiple burden we are unable to handle, and new things have happened. So there are enough PPEs, there are enough masks, but there's not enough oxygen. There are not enough ventilators, although we thought we had made so many. And also, this is just the beginning, because right now it is centered in large cities. So Mumbai and Delhi are the hubs of international travel. And we got a warning from the UK mutation that this virus is much more infective. It is much more virulent, which we did not know then, because UK believed that it spreads faster, but it's not more dangerous. But now the data coming out of the UK is saying the same thing, that it's more dangerous also. So it's gone like wildfire through Maharashtra, Mumbai, as you know, Delhi, as you know, this whole region is in serious trouble. And every morning we wake up, we hope that the numbers are beginning to decline. It is so for Mumbai that we are seeing early signs of the wave coming down because of the lockdown. Delhi also has been in 3 weeks in lockdown. I don't know what the decision will be for next week, but we are also seeing the beneficial effect of the numbers coming down and maybe less hospitalization and less demand for oxygen. In the meantime, the government, of course, in its wisdom, has made every effort to supply the oxygen in whatever form it can. So if I gave you a gross data, our medical oxygen requirement for the whole country was somewhere around 2.2 to 2.5 thousand tons a day. In the middle of this surge, it has gone up to almost 9,000 tons a day. Although India has the capacity to produce 10,000 tons of liquid oxygen a day, it is produced mainly outside of medical oxygen. The industrial oxygen is made in steel plants, which are all located in the east, and the demand for or delivery needs to be made in the rest of the country. And you need those specialized cryo tankers to actually transport it. And you've been seeing on TV these pictures of tankers being airlifted, then filled up, and then put on trains to bring to a destination. It has helped because the cycle of a truck leaving, say, Chhattisgarh, going to Gujarat and back would be 6 to 7 days because the trucks can't be driven too fast anyway. But with the government's help of flying empty tankers to the source of oxygen and putting them on trains to bring them to the destination has cut down that 7-day cycle to almost 2.5 days. So relief is on its way, but the mismatch is still there. We do have, and there is acute shortage of ICU beds, and there's an acute shortage of regular beds also. So now, all the areas you say, Kerala, Karnataka, Maharashtra, Delhi and its NCR, UP, they're all the western states are all affected by it now. And what we are seeing is it is moving east. So we expect that this wave will keep going through the country for the next 2 to 3 months. And what is worse is that it is affecting the rural area now. So it started spreading to rural areas where the infrastructure is almost non-existent. So right now we are in the middle of trying to design how we can provide relief to the tier 3, tier 2, and even rural areas as we go forward. So enough, I would just say 2-3 things. One, the medicines will not be a problem in the long run. Oxygen ultimately will get solved because with all the new sort of methodologies of transportation, of opening centers where cylinders can be filled, because the tier 3, tier 2 cities, most of them require cylinders for their hospitals, not liquid oxygen. Whereas all the bigger hospitals require liquid oxygen, not gas oxygen. So this whole thing is being mapped and will be taken care of, I think, as we move forward. So that's not major concern for this discussion. So now I want to tell you, first, what is the cycle of the COVID-19 infection? So the virus, we all know, you've heard it, it enters through the nose and mouth from droplets, but now we believe it's aerosolization also, so it hangs up in the air. This version of the virus much longer than it did before. So that means the reason why it is more infective today is because of the fact that in this ability to actually hang in the air much longer than the previous virus, which came through droplets, and once the droplets drop to the ground, then it would not be hanging around in the environment. So the basis of trying to prevent the infection came from early laboratory studies done, which showed the following. You take 2 people, one infected and one not infected. Neither one of them is wearing a mask, and they are within 3 feet of each other, and their interaction is for 15 minutes. Then the chances of the non-infected person getting infected is extremely high, because there has to be a certain viral load that gets into your respiratory system to get actually infected. Then they said, let one person who has the infection wear the mask, and the other person who does not wear a mask, and the interaction was again within 3 feet of each other and more than 15 minutes, then the infection rate came down to less than half. If both were given masks and still within 3 feet and 15 minutes, then the incidence became very low. So it showed the efficacy of masking. And then they said, if this distance is a factor, then if we double the distance, then hopefully we will even benefit it further. And the third thing was that if the interaction is brief, not 15 minutes, it's brief, then it will be even better. So with this in mind, this whole world went towards the 3 principles of COVID responsible behavior. So that's the origin of it. Again, the countries that jumped on this COVID behavior and actually practiced it and enforced it properly, they did very well. Their infection rates were much lower than the countries that did not adopt it fully, and where there was compliance was low. So anyway, with all these proof, we all went hammer and tong saying to everybody, please do the 3 things. Now let's jump to this current affair. So the current affair, this current wave, of course, numerically you see the graph going up, but how does it relate to us? The relationship is very clear that this virus mutation, and there are 3-4 of them hanging around, but the predominant one is the B117 from UK. And there is a double mutant which is found in India, but it's not seen so much yet in the cultures that have been sent to the Indian laboratories, have not really shown a prevalence of that yet. So if this is doubly infective and doubly virulent, that means we have to get the protection. We need to double it. So what is the recommendation today? From one mask, we have said, every time you go out to any place where there's going to be human interaction, wear double mask. At home, you should wear a mask because the characteristic of this infection is, in the past wave, it would one or two members of the family would be affected, but now the whole family is engulfed in this infection. So for prevention, we must double up to say double mask outside, single mask, even a surgical or cloth mask is enough. Inside the house, do not actually go too close to each other or rub bodies or shake hands. Try to keep some distance, especially from the elderly, because I'll come to that later, but especially the elderly who are very vulnerable, and you don't want to spread it to them because then you feel guilty for the rest of your life that you actually gave it to your parents who didn't survive. Third thing is, we are talking about hand hygiene and hygiene of all surfaces in the house. So that's the preventive part. And what we saw was that people thought that you are locked up in the house, everything is okay, and you have locked up your staff also, and they're not leaving the house or your premises, and they will be safe, so they're not infected. Big mystery. But in every household, the staff has been infected, and they have been the main source of bringing it into the house. How it happens, you figure it out yourself, that what happens into your staff. I think they go receive parcels, they start talking to each other. The common habit in them is to pull down the mask to talk. They like to eat together and pull down the mask and spend time together. So, in spite of the fact that your staff is in your house, let them wear masks also. So everybody in the house, if you want to stay safe, and I recommend it highly that you stay safe, please have everybody masks. Do not believe that we are okay. It's a matter of another month or 6 weeks. But if you really want to spare yourself the misery of this infection, that's all we can do. So that's the most important part, because collectively you are going into a personal lockdown. That means you are going to practice it 24 hours a day. And the next step is, if any member of the family or any individual starts getting fever, cold, cough, presume that it is COVID till proven otherwise. So that means you need to isolate yourself immediately. And the description of isolation has already been given. I'm sure all of you are aware of it. Then comes, what do you do? So you've got to get an RT-PCR that will tell you whether that person has COVID positive or not COVID positive. Now, what is turning out also is, actually we knew it all the time, that the best of samples taken from your nose and throat, there is only 75% to 80% accuracy that the virus can be detected. So, what does one do? If your symptoms are overwhelming, and those are fever, cough, significant broken body, which is quite similar to an intense case of flu. But in today's environment, one should presume it is COVID, in spite of the fact that you won't get a positive reading. We are seeing hundreds of patients coming in with all the symptoms. You do this HRCT and their blood test, and you find the classic symptoms and pictures of COVID. The lungs get affected, there are patches, your CRP goes up, IL-6 goes up, all these bloods go up, ferritin, the measures that we do, they all are positive. So that means, in spite of negative tests, you are treated as COVID and should be. So the new guidelines is, in the old days, we would not admit anybody without a positive COVID test. Today, the guidelines have been changed, which says that if the symptoms are overwhelmingly similar to COVID, take it as COVID in spite of the fact that the RT-PCR may be negative. So let's jump to the next thing. So if you give me a second, I would like to have a sip of my coffee. I saw Tej Pratap ji drinking something, so I think it's okay. Okay. So now let's talk about the infection, and or you can call it disease itself. You've heard all this, but I'll try to put it in perspective. So first 5 to 7 days of the infection, and you should go from the first day of your symptom, not only the RT-PCR test. The first 5 to 7 days are what we call the replication phase. In the replication phase, the virus multiplies in your nasopharynx and the body. That phase, basic treatment will be related to antivirals. Antivirals that we use commonly today are azithromycin, doxycycline, ivermectin may help. It is empirical data. There's no proof that it helps. Paracetamol, Dolo, Meftol to deal with the fever. And 90% of the people will basically sail through with just this regime. And you don't have to do much more. If your symptoms go away and you're feeling better, then you continue on that path. Second, especially in the next 3, 4, 5 days, you develop high fever, cough, difficulty in some breathing, same broken body. Then you need to get your blood tested to see, because the first 5, 7 days I told you was the viral phase. The next 7 to 12 days is going to be the inflammation phase, or what we call cytokine phase. That is when the body mounts a defense attack on the virus. In the process, if the response is excessive, it will produce a lot of inflammation in your body, and it affects everything in your body. So if that happens, you will know, 1, by your symptoms, and 2, by your blood tests, and 3, if needed, if the blood tests are indicative, by HRCT. So these are the 3 things that will tell us that you are actually got infected. You're not the routine 90%, you're the next 10%. Now, our main effort treatment at that time, and antibiotics really don't help unless you got secondary infection. That our main effort is to blunt the immune response of the body. And that's when you've heard that cortisone or steroids are used very effectively. And depending on the degree of the inflammation, we choose the dosage and the methodology in which you want to give it. So if it is mild to moderate, we will say oral medicine, Medrol, you'll hear many names, dexamethasone, Medrol, all these things the doctor will tell you. And if the response is very good in the next 24, 48 hours, then we continue on that. If the response is not that good, we may convert it to intravenous therapy. Okay, now when we stop here, you have heard the word remdesivir. Does remdesivir play a role? Remdesivir was actually invented against Ebola and SARS-1. But it was lying on the shelf of Gilead, which had done the research, but by the time it came to market, SARS had already disappeared, and Ebola was also disappeared. So in this SARS-2, because it is similar to or a different version of the SARS-1, they repurpose this medicine as an antiviral. So you'll hear Favipru. Favipru is a Japanese drug, antiviral drug, and remdesivir. Now, we really don't know the actual benefit of it. We know that there are some studies which say that it makes no difference in mortality. Means that if you gave remdesivir or not, the people at the end, the numbers who are going to die will die. It is not making any difference. That's one of the indicators we use as a success of a therapy. But it showed in some studies that it shortens the illness by 5 days. So if that's the case, then it's still useful. But it's useful in only the people who have very high viral load, who are showing signs, so it must be given in the first 5 to 7 days. And that's when we think it has some benefit. So everybody doesn't need it. Only very select people will need it, and let the physician who's trained to prescribe it for you. So you, as an individual or any individual, does not necessarily need either Fevipru or Remdesivir, only if we believe that the viral load is high and is showing the symptoms of high viral load, only then we will give that. So that hopefully answers your question about Remdesivir, because you don't want to give any drug because all of them have some side effects. Similarly, in cortisone, we have seen many mistakes made, that in the replication phase of the first 7 days, somebody starts steroids, it will suppress your immune system and it will only help the virus to multiply even further. So you've actually done damage to the person. So that's when we need to clearly know the signs and clearly be directed by a trained physician. Now we are going on that journey. We are looking at our oxygen every day. Everybody is looking, even if you don't have COVID, people have got pulse oximeters and become conscious. So we say, if your oxygenation drops below 94, 93, then maybe you should go to the hospital. That's not correct by itself, by the way, because everybody will experience some drop. Above 90, your body does not experience any deprivation of oxygen. This is the normal, because the dissociation curve is flat after 90, the SpO2 of 90. The other is still number. You may have it in your blood, but it's not doing you any damage or any good. So we should know that the reason why we are saying 93, 92 is to give you a little bit of a margin, that in case it gets worse, you are aware of it. That's the idea behind it. But it is misunderstood, because people, the moment they see 94, they run to the hospital. That's not the case. You don't need it. But be guided by the doctor who's trained to do so, because we can treat at least 50% of those people or more who have drop in oxygen at home with oxygen, whether it comes from a cylinder or it comes from a concentrator. So people will experience 3-4 days of a little lack of oxygen. When the steroids kick in and the inflammation starts fading, it comes back. The second thing is that thanks to the 50 autopsies done by doctors in Bergamo, Italy, where they did autopsies on 50 post-COVID deaths, and they discovered that two things, which is very important. Before that, the belief was only that the virus would affect your lungs, and that's what killed you. That was not so. The virus does affect the lungs, and the patches looks very scary, but the actual mechanism is that the virus goes through to every organ of the body and was found in the liver and the kidneys and the brain and the heart. So this inflammation that spreads affects all these organs. So what you will see is that this inflammation will also reach the arteries of the whole body, and mainly the smaller arteries, the capillaries. When their wall becomes inflamed, the blood clots inside it. So the mechanism of death was that the lung capillaries, which exchange the oxygen from the air into the blood, they get clotted, and there is not enough blood flowing to affect that exchange, and people die of asphyxia or lack of oxygen. That was the mechanism. So if we find inflammation, and one of the tests that we use is D-dimer, which tells us the intensity on which the coagulation factor is, we immediately will give heparin or another blood thinner along with cortisone. So at this stage, cortisone blood thinner are the two main drugs. But God forbid, the inflammation turns into that cytokine response turns into a cytokine storm. The cytokine storm is that the release of cytokine is so intense that it actually makes it even worse and everything goes haywire. The kidneys may fail, the liver may fail, the brain may have effect. That's when we fear that beginning of the storm, that cortisone is not working enough. In spite of intravenous, we talk about tocilizumab. Tocilizumab is the other drug you must have seen. It's in the news that it disappeared from the market. People cornered it, started doing black market in it. So the government, the next shipment that came from Switzerland, it's not made in India. The government seized it and now it's being given by government quota. You apply to the government and they will assess. There's a panel made which will assess whether you are a candidate for it or not, because everybody is not. So that's why, and it's a dangerous drug, because given under the wrong circumstances, it can unleash severe infection in your body because it's suppressing the immune system. So it has to be carefully thought through. People who are extremely knowledgeable for it should be only able to prescribe it, and then it's given as a lifesaver. So that's the sequence of events that go through. Now, if the oxygenation is hampered to a degree that somebody needs ventilation, then we will put that person on the ventilator. So now, if you look at the full stack, 90% are at home, 10% will require hospitalization. Now, between the 90% and 10%, there is few percent who don't need to be in the hospital but require oxygen. So now there are step 1 facilities created where oxygen is available and you may not need to go to the hospital, but you can go to those like we have done from Medanta, Red Fox Hotel. We have taken over, our nurses and doctors are there and we supervise, but they don't need to be in the full blast hospital. Those we save for people who get more serious. Anyway, this is the lay of the land today. So now coming back to what is so neither is remdesivir a silver bullet, nor is tocilizumab a silver bullet. Now what are our options? And the only option is vaccine. Vaccine would be helping us hugely. It's not a cure, but what it does is it gives you protection against severe fatal disease. So we were the first people to get vaccinated as healthcare workers and frontline workers. And so almost all the doctors and frontline workers, most of them got their 2 doses and 2 weeks out. So there are 2 vaccines. There is the Covishield and the Covaxin. The question was which one is more effective, which was safer, what will give you more protection. So I'll come to that. But then we found that it was true that it gives you protection against serious illness. So enough doctors and paramedical personnel have got infected. When I say enough, it's about 5%. Not much, but it's enough. So those 5% we find that maybe 0.001% may require a hospitalization. The rest are all mild and they are recovering at home. So it does give the protection which the vaccine promised. Now, if you look at it, Covaxin was started and it was started in government hospitals by the government, central government hospitals. Covishield was available to the rest of the medical fraternity. So we thought, is there a difference? Then we found that equal number of percentage of doctors and paramedical personnel are getting infected again on both sides, on both vaccines. But the same result that we have not seen a death and we have not seen any serious hospitalization. So it does give that protection. Now, the question is, there is an acute shortage or limited supply, I should say, limited supply of vaccine. Now, if there is limited supply, what does any country do? They categorize give it first to the most vulnerable, then the next vulnerable, next vulnerable. So it was going quite well. There was too many people wanting it who were not included in the groups that the vaccine was going on. Then from too much intense pressure from everywhere, the Prime Minister recapitulated and said, open it up and let the private sector get it from the companies and you inoculate. This is your price. Unfortunately, that has disrupted the whole system. Because it wasn't what it was, maybe it was thought through, but nobody cared for it, or it wasn't thought through. That is, big chains can go to the companies and say, I want to order 10,000, 20,000, and I get it when I get it, but I have to put down a check for 1 crore, 2 crores, 3 crores, depending on the. But what about the small nursing home guy who only needs 10 vials? He's out of the system. So there are certain flaws in this policy which we have brought to the attention of the government, and hopefully some action will be taken soon. But vaccine has come to almost a standstill today, and a large number of people who got 1 dose are finding it difficult to get the 2nd dose. Now that's almost criminal that you are hanging them in the middle. So there are these, hopefully ASAP, something will happen. But now there is Sputnik. Other vaccines will also come in. There's another vaccine made in India, which is the DNA extracted vaccine. So there is DNA, RNA, attenuated virus, and dead virus. There are 4 techniques. So Pfizer and Moderna are, as you know, RNA. These are all genetic materials of the virus, and then they are introduced into the cell of the human cell, and the human cell develops the protein to fight. So there's a little complex 2-step procedure. And then there is Johnson & Johnson, which will be 1 dose, but they all seem to be equally effective or equally non-effective. But what is the experience around the world? People who have been vaccinated get mild form of the disease. That's a truism. Okay. So I think I've overstepped my time, but this is a story I wanted to tell you end to end. But remember, this is something not to panic about, but be extremely fearful of. I would not like to give you any false assurance that, oh no, don't worry about it. You should be worried. You should be worried about yourself. You should be worried about your family and your community. And you have a huge burden for the students. Now, remember, nobody's safe till everybody's safe. So our effort is that we must get everybody inoculated in as short a period as possible. Thank you. Thank you so much.
Sure. Thank you. Now, question hour session. I would request to Madam Pankaj, Madam, to kindly invite the questions from the audience. And one by one, sir, I would like to mention that too many questions from ministry side also, I think forward on WhatsApp. And two other vice chancellors, our honorable vice chancellor want to raise the hand.
See, that is my trick. I'll talk for so long that people don't have time to ask questions.
And then, sir, we will request you for some extra time.
Yeah, I am okay. It's up to you.
Okay. And thank you very much, sir. It's really a spellbound talk, and starting from how to prevent and ending on the vaccination and various phases of the disease. It was really exciting and very, very knowledgeable and very, very informative talk. So thank you for that. So we have some questions with us, and I'll also request the Vice Chancellor if they want to ask. But I'll start with the question, sir. Like when you were telling about the phases of the COVID, sort of how the disease progresses, you talked about the replication stage, that first 5 to 7 days are replication stage. And then you also mentioned that remdesivir can be given only in the replication stage. Maybe that will be more effective during the replication stage. And the steroid should be given in the inflammation stage, that is after 7 days or so. So that means remdesivir and steroid cannot be combined because the duration for the both is different. But then we see that mostly remdesivir and steroids are given together. So is it a right treatment or a wrong treatment, sir? One is that. And second is you spoke about oxygen concentrators and oxygen cylinders. So when we are sort of treating the patient at home, what will be better, oxygen cylinder or oxygen concentrator? And third, which I have already got, is that the difference between the two jabs, I mean, it was at 4 weeks for Covaxin, and for Covishield, earlier it was at 4 weeks, then 6 to 8 weeks, and now they're saying 8 to 12 weeks. So what is the right thing? So these three questions right now, sir, but there are so many of them, I don't know how much time you will have to answer them, but initially these three questions.
So let's go one by one. You made too many questions. What's your first question, which you want me to answer first?
So remdesivir and steroids.
Very good question. Okay. So what happens is, as I said to you, the replication stage will tell you how much is that load, viral load. So viral load usually doesn't come in the first 2-3 days. It comes at the end of the first cycle. So usually you will see remdesivir started somewhere 5 or 7 days. And it's a 5-day course. But in the meantime, if the inflammation is climbing and you want to abort the inflammation, you will start steroids overlapping. So it's not that one is exclusive of the other. It's just the mechanism, what you want to fight is end of the virus or the viral load is enough. You want to now try to control it. As I told you, there is no real evidence to say the virus actually gets killed by it. But there is a point study which says it reduces the illness. Okay. And then you may show it's very well that 2-3 days of that treatment will overlap. Okay. So that's answer question number 1. Question number 2.
Oxygen concentrators versus cylinders at home.
Okay. Now the advantage of a concentrator is that it is with you and it will hopefully keep producing oxygen for you so that it doesn't run out. But the disadvantage of the concentrator is that if it's a 5-liter concentrator, which is the most available one, and there is a lot of quality issues here also, that over 3 liters, they don't really produce, some of them don't produce 4 or 5 liters. So if you are between 2 and 4, 3 liters, you're okay with the concentrator. The cylinders are more effective, most definitely, because you can dial up and down. But the bad part is they run out. And then we have to go get them filled somewhere, which is not very easy today. So in the absence of availability of unlimited supply of cylinders, it's better to use the concentrator for now.
And sir, the difference between the two jabs, especially in case of Covishield?
Okay, so I'll tell you what the whole confusion where it was caused. Covishield is basically UK based. When they started vaccinating, they said there's not enough. So maybe if we broaden or widen the gap between the two jabs, we'll be able to vaccinate more people. And that maybe there will be no difference, or they even somebody said maybe it's more advantage. Nothing, no proof of all this. It was for the convenience of the country that it was proposed. India went through the same paces. We said 4 weeks. Then we said, okay, maybe we have the same problem as UK had, let's extend it to 8 weeks, to 12 weeks. But little do you know that the first dose does not give you immunity. So you may have gotten the first dose, and between the first dose and second dose, hundreds of thousands of people have got trapped. That they got infected in the middle of before they got the second dose. So that's why I think it is not a good decision. Although it's a decision somebody policy makes, but that's not a good decision. We all got it at 4 weeks. All doctors got it at 4 weeks. So if that's an indicator, maybe people ask me now, I said, make it 5 weeks, man, it will give you mental satisfaction.
Okay. And sir, some people have asked, some people have some comorbidities. So can they take a vaccine, and even a pregnant lady can take a vaccine?
Well, in India, it's not very prevalent. There's not a very clear guideline. It was in the world, it was felt that there was not enough experience with pregnant ladies and breastfeeding ladies, so lactating mothers.
Okay.
But now the FDA in US has started permitting. Now, There's a difference between the vaccine over there and the vaccine we are using. So I think that we need enough experience to be able to say yes, safe. I won't say yes today.
Thank you.
That is just my caution. So just wait.
So we have with us Dr. Vivek Sahuji, who is himself a medical doctor. He has raised his hand. May I request Dr. Vivek Sahuji to ask his question?
Thank you, sir. It was a really wonderful talk, and I mean, you explained it in a very simple terms as to the genesis of the disease and all the stages of the disease. Thanks to the AIU for organizing this. My two limited points, as Madam has said, I am a medical doctor, and we are also in the thin and thick of fighting the COVID. So, I mean, we are already in the thick and thin of the second wave. And people in the responsible position are talking about the third wave. I know, see, it's all uncertainties. We may be, because eventually we'll not be able to vaccinate as many. And so we have to be prepared for. But I mean, rather than focusing our time and energy on the second wave, I think people are talking. And I think this is adding to me an element of fear in the minds of the people. Or I don't know if that's the purpose or that's the agenda. But I think your views on that. And secondly, I think, this is a common question asked, that initially it was in Maharashtra and then it started all over India and so on. And it is probably the travel time and so on and so forth. So some of the people, they keep asking as to the neighboring Pakistan, which is as good or as bad or maybe worse than what we have. But there, and in fact, one of the international news channel yesterday was showing that Pakistan, in spite of all these things, is still much, much, much less. So, I mean, what could explain some of these disparities? Your views, sir.
So the first question you asked was about the third wave.
Right.
So as you are an academic, that it is a very common thing for people who want to show that they are relevant, that they will start talking of what other people are not talking. They will try to talk ahead. They have no idea, by the way. There are talking heads on the TV who actually let off gas. They don't have no idea where the wave is coming or not coming or how high or low it's going to be. It is from the history of Spanish flu that everything is being extrapolated. That if the second wave came similar to the Spanish flu second wave, there must be a third wave. And usually the third wave is milder. That's what history teaches us. There are similarities of the same kind. This is like the ditto imprint of what the Spanish flu did. Because we thought, like I told you in the beginning, we thought BCG, we thought hot weather, we thought immunity, all that didn't work. This virus and its mutation has its own mind. So the question is, you're very relevant to say, let's focus on talking about scale. By the way, if we suffer through this wave, we will be 100% ready for the third wave anyway. There is no rocket science to that. Unless the third wave is 800,000. Then we might as well say bye-bye to ourselves also. That then nobody will survive. And we don't know. Actually, this is like, if you look at in India sitting here, we talk about Parle. This is like Parle. That culling is going on. X number of people will be eliminated from this world. So I think that it's useless. Your point is very correct. It's useless to talk about third wave. Let's concentrate on how to solve this wave.
Right. I mean, that's what I mean. I felt, and people who ever be at power.
You see, don't tempt me to use more names for those people. Because they're irrelevant. Just to stay enough, they're irrelevant. But when they are called on TV, they have to say something. We all sound like experts. To tell you the truth, we have no idea. We are all second guessing. All that I've told you is if you ask me that for every word I said, do I have scientific evidence? No. But there are observational evidence. There are many things we don't know about this virus. So why are we behaving like, we have knowledge which you don't have?
Right.
Just the fact that we are dealing with it on a daily basis. So we have observed certain things. Our knowledge is based on all that. And what we read about the international literature, the research we did, like we did research, on Ayurveda and COVID. So we have found the effectiveness of Ayurveda in not only in the phase of COVID but post-COVID stage, because that's another syndrome. Post-COVID is going to create havoc. People will have many problems, including heart problems, lung problems. This is another story which will take another hour for me to tell you. But that's what it is. So don't pay any attention to these people who make you feel like they have some wisdom which we don't have. Okay, second was your question.
No, second was in Pakistan is as bad, and I mean, we
No, but
cannot-
the best way to do it is don't test. You'll never know what happened. Don't take any data. You won't know how many died. So that's one way of hiding everything. So that's why you say today there is more testing, and we don't even know what the real peak of the first wave was because there was not enough testing.
Okay, yeah, that
Maybe
makes
it was
sense.
200
That
and
makes-
this one is 800. I believe it's probably 1 million today, 1 million a day. This is what I believe.
yeah,
Because if you test the whole country, you'll find 1 million more people.
Yes.
yeah.
Okay, so Dr. Razdan, you were
Sir, go
going
ahead,
to
sir.
lifting your head or was saying bye-bye to me?
No, sir, Professor Ramesh Goyal is there, sir. Professor Ramesh Goyal.
First of all, I would like to thank AIU and Dr. Trehar for giving such a wonderful and very simplified talk. Well, I'm a pharmacologist, so I will be very pointed to ask a question. The target is ACE2, and this molecule was discovered in 2000, around 2002-3 or like that. Now, I wonder why this target is not taken for development of drugs, because it is not only the spike protein leading to multiplication, but also the cytokine surge. Even the other actions which are there, including D-dimer probably, or the post effects which are coming, including pulmonary fibrosis to CNS to all, they are all related to ACE2 as per our whatever preliminary research we have done. My question is that, can you comment on that? Because we have already come out with one formulation. We are trying to do that. We are waiting for the Ayush approval. We are going to submit the data. But I wonder that there are some trials failed. The monoclonal antibodies and all, they tried to do that with the ACE2. But if this molecule is taken a little more seriously, probably we will be in a position to better. This is what is my prediction, but I would like to hear from you.
No, very pertinent question, sir. ACE2 inhibitor is where the spike protein attaches. You're right. You know that statins actually block the ACE2 receptor. So there is a study, not well recognized, but there's a very large study of 6,000 patients from Florida, which says that it's an observational study, which says that it seems like people who have been on statins for long periods of time have a much lower infectivity rate than people who are not. This was an observation long time ago, maybe 6-8 months ago, that this came. So now the point, it sort of belies your point that there is some currency in actually blocking the ACE2 receptor, because it's like docking. The spike protein docks into the ACE2 and then multiplies, right? So if you can block the docking, I'm sorry, everybody's looking puzzled of what the hell we are talking about. Maybe you and I should talk about it offline. So ACE2 is one of the receptors in the body, which anyway, we'll talk about it later. But your question is very pertinent, and anything you can do to enhance this research will be very, very valuable to the society.
So we have already done it, and it was proved actual virus, the expression was we could observe, and that is the primary evidence on which we are moving further.
No.
And sir, one small question, because as a cardiologist, D-dimer is a very, D-dimer is causing a problem at times. See, the normal limit is supposed to be 500, and that people, when it comes to 700 or 1000, sometimes I feel that probably it is a viral, it is a fact, but one should not be panicked. But if it is around, because I have seen the cases 5,000, 6,000 also, 2,000 is. So what is your recommendation with respect to D-dimer?
See, it's a benign enough therapy. If you put somebody on low molecular weight or even oral Eliquis, kind of drug. So then it has very low risk of using it. And there is since we have seen such many heart attacks, many people getting strokes, many people getting kidney failure, that we believe that this is a real entity that you can get clotting of your arteries and capillaries. So why risk it? So if it is elevated, you better respond to it rather than take the risk of major problems. Because if you get a stroke or you get a heart attack, that's done. And now there's a whole new study, work that we have done on the effects of virus on the heart and why young people are dying with total sudden collapse. So that will take a long time. So hopefully this will finish so we don't have opportunity to talk about it again. But in better times, I'll be very happy to share that information. So, okay. Now, any other questions or?
Sir, there are many questions, but we are aware that you are busy. But some very quick questions, sir, which are
Walk up to
everybody. Some very quick questions. One is, sir, they were on the chat that if somebody is getting chemotherapy, can he be vaccinated? If somebody is having high IgE level or hypertension, can that person be vaccinated?
Yes, should be.
They should be. Okay.
Should be, absolutely.
And once, sir, somebody is asking, I don't know what is OC. OC should be 5 liters per minute, or OC should be 5 liters per minute or 10 liters per minute?
OC is an oxygen concentrator.
Okay.
Yeah. So the safer one is 10 liters. If you can get it, they are in short supply.
Yes.
So 5 liters is what you're getting mostly, and they're coming from China and they're of different quality. So you don't know whether you're getting the right product. But
and then, sir, if somebody gets the first dose of vaccine and gets infected with COVID after the first dose, after how many days the second dose should be taken?
6 weeks after being declared free of COVID.
6 weeks after being declared free of COVID, and free of COVID will be through a test?
4 weeks, 2 weeks is what 14 days is what we say is the COVID phase. 6 weeks after that.
Okay. So that means 8 weeks from the onset of COVID.
As a thumb rule.
Okay. And then, sir, you talked about post-COVID. I'm not talking about the symptoms, but what about the post-COVID care which the people should take once they're infected with COVID?
Okay. So it's a very good question. I'll make it quick. If you have a mild infection, that means that you sailed through it. The misconception is that I didn't feel much, so I can go and exercise, and the more deaths in that group is the highest because they are still suffering the myocardial inflammation. And they go and exercise vigorously, they will get irregular heartbeat and collapse. So the warning is, do not try to become a Superman soon after you have recovered. Take 4 to 6 weeks to condition yourself again. That is one group. The other group who get more severe, who get lung problems, if your lungs get involved, they need a lot of rehab for their lungs and also for their muscles, because people start getting what we call fibromyalgia, and they need therapy for that. So this is a full science by itself. We have what we call a cardiopulmonary exercise. We do the testing to see if your lungs are compromised or your heart is compromised. It tells you what's what and how much you should exercise without being in danger. So this is a full new. And also we have a new device which we call AliveCore. That is a device which is the size of like a pen, half a pen, and you hold it in your fingers and touch it to your skin, and your complete cardiogram comes to us in our remote sensing center at Medanta, which is our command center. And this ECG can be monitored for people who are possibly affected with heart or with previous pre-existing heart disease. So we were using it for our own patients before, but in COVID, it's become even more valuable. So that's the way to monitor. Okay. So can I take your leave now?
Thank you, sir. Thank you. We are not wanting to leave you, but time is not permitting.
I respect you guys because you people are actually shaping the future of this country. So my respect to all of you. Okay.
Thank you, sir.
Thank you very much. Thank you very much, Ranji.
Handling students is much more stressful than handling people.
That mental counseling thing also we wanted to ask, but time is very short.
Maybe another session sometime later.
Yes.
Well, I would be very happy to do that. Okay.
Sir, please, sir.
Sir, I would like to really, on behalf of Association of Indian Universities and myself, to thanks to Dr. Naresh Theran, sir. So really, in busy schedule, sir, you accepted our request, and there is no word. But definitely we have more questions, and we would like to again request for only question hour. We have too many questions basically on our chat box, but in some other time definitely we really request you. And you know this, when to organize this program, have too many people from your side and from the AIU side who really help. I would like to first to thanks to our Secretary General Madam. It's very dynamic. Always basically to think over to how can we facilitate our member universities, what will be good. And thanks, madam, for your really such thoughtful thing and support it. And all behind that, our president of AIU, that is already Tetlab sir here, who is always source of inspiration. And our the vice president, sir, sir is here. Sir, namaskar, sir. Sir, always your support behind. And we'd like thanks all member university vice chancellors, directors. Sir, without all of your presence, the program will not possible. Because the beauty of the program, when people really participated, and it's really to reach to you. So I'm really very thankful when I receive questions and the thanks. So it really motivate further for such type of session. How can we benefit? How can we issue masses? And secondarily, I would like thanks to from the office, basically our Vijay Kumar ji, our assistant in office, supported, and Satyapal Singh ji, PS generals, always in touch. And not when that suits when Dikshit ji is an IT expert person. He already is in front of his family member, but keep in touch. He's guiding our deputy secretary, that is Kuldeep Dagar ji, always in that to how to make possible. We exceeded last moment. We when request that we exceeded the number of participants. How people requested we want to join. We requested to join basically to on YouTube, see on YouTube and other. But therefore, so that we request for extension this thing. So thanks Kuldeep Dagarji for that to really to make it possible. And beyond that is from your office. I would like to really mention that is the Jugal Kishorji who really to help to coordinate in whole program and be so kind. And is Manish ji.
Manish.
Yeah,
Manish.
He said. Yeah. And you're really IT person, very really enthusiastic about it, and the all IT person, Umang ji, and this one our colleague, yes, I think Dinesh ji, who in late night also the trial for that 2-time trial for it goes well. So have too many person behind that who really supporting. Finally, I would like to thank sir, and I'm really personally thankful to you that. You so kind. You discussed our program around half an hour in the morning, 8:30, and that was really the beauty how it goes and how you really to want this thing. So really, again, sir, we would like definitely as you also this request again some good time. We want your valuable time to address our honorable vice chancellor. Thanks again. Thanks to everyone.
Thank you.
Thank you, sir. Thank you, and looking forward to see you again.
Thank you to one and all. Thank you. Have a
Thank you, sir.
Bye-bye.
Thank you very much.
Thank you.
Thanks.
Pleasure.
Thanks. Thanks sir. म्यूट कर दें सभी को.
सभी को नमस्कार. बहुत बहुत धन्यवाद.
नमस्कार. सभी को म्यूट कर दीजिए.
ठीक है.
Thank you very much.
Namaskar, sir.
Thank you very much. Good program.
Oh, sir. Thanks, sir. Thanks. So nice.
Alok.
Vedanta ji. जी मैडम हेलो हाँ मैडम रमापानी मैडम नमस्कार मैडम कुछ और आ रहा था
मैडम को भी थैंक्स बहुत अच्छा रहा वेरी वेरी इंफॉर्मेटिव
जयसवाल सर नमस्कार सर
नमस्कार जी नमस्कार
डॉक्टर पंकज मित्तल मैडम को और आलोक जी आपको और सभी टीम को मेरा अभिवादन एसके श्रीवास्तव का
बहुत बहुत धन्यवाद जी आपका
थैंक यू सर थैंक यू एसआरएम सर पीछे दिख रहा है हमें जानकारी कि आपने 5 ज्वाइन कर लिया सो दैट थैंक यू सर अगेन दैट्स नमस्कार सभी को एंड आई थिंक दैट्स अ गुड पीपल गुड स्ट्रेंथ टू जॉइन एवरीवन Thank you.
At one point of time, people crossed 250.
Yeah, sir. Don't see in the reach. And on YouTube, that is a reach to around 560 some.
Very good. Very good.
Yeah. So on YouTube, they reach there. So good.
Namaskar, Professor Jaiswal.
नमस्कार जी कैसे हो शर्मा जी?
I am Ratan.
हाँ जी रतन जी.
हाँ जी क्या हाल है?
बिल्कुल ठीक है वीके जी.
So very good. I think that's RK. That's Madam or someone is there. Okay, thank you, sir. Then we will see again that we will maybe your advice and we will advise.
Thank you very much, sir. Thank you so much.
Thank you, sir.
Thank you very much.
Thank you. Now with the permission, we are going to end the session.
Gohel Sahib, how are you? Dr.
Yeah.
Gohel, how are you?
All fine, very good. Thank you.
So Manish ji, I think formally that NCC soon some other program.
Right, sir.
Some advice.
Sure, sir. Definitely we will make it.
Okay, Manish ji, so really thanks a lot.
Thank you to you, sir. Thank you to you. Thank you to madam.
Yeah, that's it.
For the wonderful program. Thank you very much, sir.
And send a collaboration this.
Sure, sir.
Yeah.
Sure.
So we'll proceed. Hai na? Thank you.
Thank you.
Okay, Alok ji, Pankaj ji, thank you very much for wonderful program.
नमिक जी कैसे हैं आप?
बस सर मैं 5 दिन हॉस्पिटल होके आया.
अरे
I was in और
fully recovered.
Fully recovered now at home.
That is good.
Thank you.
Okay, Manish ji, now end of the session. And,
Yeah, thank you, sir. Thank you. I'm ending the session. Thank you.